So yeah, physical examination can be really useful, as we saw in these two examples, and I actually um, added some other examples in this paper to kind of look into other physical examination that might be a little bit simple and still useful by evidence. So, but at the same time, to be honest, not all the physical examination finding that we learned during medical school are actually useful. So, in the other kind of contrary paper, I also gave some example of other physical examination finding that I think probably we don't need to really seek, or we don't need to train the coming physicians to do. I usually don't ask my resident if they haven't done these physical exam findings at all, because I don't think they're clinically useful. And that's also suggested by some evidence. Again, as you can imagine, the evidence with physical examination test is not going to be like, very robust, but at least that's what we have. And also, if you add to that common sense and you add the other advantages of physical examination, you can really get a sense about the balance between how physical examination can be really useful even with a modern diagnostic test, and what physical examination that might be less useful, and you might need not to waste your time doing them. So a very useful concept that I think in the evidence-based medicine era is really important to know is the concept of the likelihood ratios. So I really want you to understand this concept really, really well, because it can help you understand which physical examination findings can be useful and which physical examination findings might not be useful. So basically, the likelihood ratio, it's the likelihood that I will find the test or sign in those with the disease compared to the likelihood that I will find it in those without the disease. And I know it's a little bit confusing sometimes, but it's really kind of a function of the sensitivity and specificity. And there's two types of likelihood ratio: the likelihood ratio positive and the likelihood ratio negative. The likelihood ratio positive is basically the probability to test positive if one has a disease divided, which is basically the sensitivity, right? Divided by the probability to test positive if one does not have the disease. And vice versa is the likelihood ratio negative, is the probability to test negative if one has the disease divided by the probability to test negative if one do not have the disease. I know it's confusing. I know the sensitivity and specificity is always confusing, but basically the likelihood ratio is a number that can tell you, if you find this test in this patient, how likely this patient has a disease. And if the patient does not have this patient or does not have this sign or physical exam finding, how less likely that the patient really truly doesn't have the disease. And I'll give you the example in the next slides. So as a concept of the likelihood ratio are really useful when you think about the pre-test and post-test probability using the Bayesian theory. So basically, I probably try to explain it with using the D-dimer because in pulmonary embolism, because I think a lot of students, they understand that, if you ask them what do you think about the utility of D-dimer in PE, they will tell you, well, if it's negative, then it really makes PE unlikely, and I don't want to do any other further testing. So basically, if you have, for example, a young patient coming to you with right-sided chest pain, you think it's musculoskeletal, but the vital signs of the patient is a little bit tachycardic, and then they mentioned that they had a trip for like 3 or 4 hours, not too long, but not too short at the same time, and you really think that should I test for PE or not? You think the probability is low. If you do the Wells score, for example, it's probably going to be low. It's probably less than 5% because there is no other risk factor for PE, but you're still not 100% sure. So what you do, you start with the pretest probability in the lower side, less than 5%, for example, and then you do the D-dimer test, and you know that the D-dimer test has a likelihood ratio negative of about 0.1, which is very low. So that D-dimer came back negative, as you really want it to be. So it will take you here, for example, let's say the pretest probability is about 2%, 5%, somewhere here, and then you draw a line to 0.1, which is a probability for the or the likelihood ratio for a negative test, a negative D-dimer, and then you just continue the line, and they'll take you all the way to less than 0.5 or 0.2%. So this is really very small probability that the patient is having a D-dimer with a positive. The patient is having PE with a negative D-dimer. That's why the D-dimer is useful when the probability is low, because think about it. If you have a patient with, for example, the same patient is elderly, he's having history of cancer, it's like pleuritic chest pain, well, the probability is really high, let's say 80-90%. So why do you want to do a D-dimer? If the D-dimer is negative for any reason, even with that, if you draw a line between, let's say, 90% and the 0.1, it will take you to what, 40-50%, which is still like a high percentage, and you still be suspicious, and you still probably want to do CT PE protocol to check for pulmonary embolism. So that's why the D-dimer here is useful when the probability is really low. So you don't have to carry the nomogram with you all the time, but really just think about the concept. So you think about what the pretest probability is. Is it low? Is it medium? Is it high? You can always use a scoring system that has been validated in studies using evidence-based medicine, and then based on the likelihood ratio also, which are based on prior studies, then you can come up with a theory about the post-test probability of that diagnosis. Now, a nice table that you can roughly memorize is that takes into consideration the likelihood ratio numbers. So any likelihood ratio close to 1, it means the test is really not useful, even if it's positive or negative. You want a likelihood ratio positive to be really high. So a likelihood ratio positive of 10, for example, will increase the probability of the diagnosis you're seeking by about almost 45%. And likelihood ratio of 2, it might increase a little bit, about 15%. And then for the likelihood ratio negative, if it's really low, 0.1%, that really decreases the probability of the deceased by minus 45%, a great deal. Compared to if the likelihood ratio negative is 0.5, it only decreases the probability that deceased by about 15%. So this is just kind of a rough estimate to think about, the likelihood ratio. You really want the likelihood ratio for your physical examination finding to be in the higher side, and you want the likelihood ratio negative to be in the lower side. We'll give a further example using heart failure and pulmonary embolism. Now, think about your patient with CHF. We always say that heart failure is a clinical diagnosis. It's made at the bedside from history and physical examination. So what does the evidence say? What the data suggest regarding the usefulness of physical examination in CHF? Are they really useful or not? So some data suggest that, for example, the jugular venous distension can detect if it's positive and elevated, then it suggests that the CBB might be like 12 or more, and if the patient is having with the likelihood ratio positive of 10, which is high as we saw in the nomogram in the previous slide, and if the patient is having a positive abdominal jugular reflex, that likelihood ratio is still high also. So the JVD it seems like it's a useful physical exam finding in patient with CHF. Also, supine apical impulse lateral to the midclavicular line to suggest low ejection fraction was found to have a likelihood ratio positive of 10. That sounds like really a useful sign as well. And then the third heart sound is also about 6 to 7. So if you have a patient with shortness of breath and you find a S3, that also increases the probability of CHF. Tachycardia also is very common in patients with CHF. The likelihood ratio is 5. And then the crackles to some extent, but it's not really found in every single patient with CHF, it seems like. Remember, some patient had really very effective lymphatic drainage, and the accumulation of fluid in the lungs might not be evident because of that mechanism. And the study suggests that not every single patient with CHF might have, if you have a patient with crackles, there are other causes of crackles as well, so the likelihood ratio is not very high. The same for edema, and I really saw that a lot in many patients. it seems like sometimes it's very common that medical student will tell you the patient doesn't have edema, and that might be biased by that, and they might think that CHF is very unlikely if they don't have the edema. But data suggests the other way around. It's actually, yes, if you have edema, it might give you a clue, but remember the other causes of edema as well, including liver disease, kidney disease, and also if the edema is negative, actually it's not very, it doesn't really make CHF very less likely. So JVD might be very useful. Apical impulse just deviated from molecular line might be useful. Theta sound might be useful, but edema and crackles might not be as useful as the other physical examination findings. Now compare this to pulmonary embolism. Think about it. How useful is physical examination in patient with pulmonary embolism? Do you feel confident making the diagnosis of pulmonary embolism based on your physical examination compared, for example, to CHF? And let's see what the data actually suggests regarding the likelihood ratios and usefulness of these various physical exam findings in pulmonary embolism. So there is, when it comes to respiratory rate more than 30, the likelihood ratio is actually 2. It's kind of small. What about tachycardia? Yes, it can happen with pulmonary embolism, but the likelihood ratio is really 1 to 2. It's also small. Left peritoneal heave as a sign of right ventricular strain, the likelihood is between 2 and 3, so mildly to moderately increased. The new gallop is also 2 to 3, so mildly increased. And then unilateral calf pain or swelling is still between 2 and 3, so it's only mildly increased. So yeah, exactly. It's for pulmonary embolism, a lot of physical examination findings are not really very helpful, and that's why you still have to look for these physical findings, but or maybe not. But you have to keep in mind that your examination is not going to help you that much, at least compared to other pathologies like CHF. And that's exactly why we have scoring system to make the diagnosis of PE and DVT, like the simplified Wells score and the modified Geneva score. And these score systems, they really kind of make they take advantage of combining physical examinations, because one thing about the physical exam and likelihood ratio is actually if you combine them, they might increase the probability, especially if they have different underlying pathophysiology. So if you see 3 or 4 of typical findings of a pathology or disease, yes, that might increase the probability, even if the individual physical signs are not very useful. So I hope that I made it a little bit clear regarding how physical examination finding in different pathologies based on the likelihood ratio can really be useful clinically or less useful.